I met Andreas 3 years ago, I think, in the Romanian hernia days in Transylvania. So it's my pleasure to have him give a talk here today. He's a very prominent European hernia surgeon and a special interest in sports, elite sports athletes, groin problems. He's the head of the department, the Day Surgery and Hernia Center in Cottbus, Germany. And I'll be happy to hear him give a talk on the Shouldice repair today.
Good morning, everybody. It's a great pleasure for me to be a part of this virtual conference and to talk about the Shouldice repair. Many thanks to David for the invitation to this talk. And in the following minutes, I want to talk about the Shouldice repair, the indications, and why we have to talk about pure tissue repair in times when we are talking about mesh repairs, robotic repairs, laparoscopic repairs, etc., etc. At first, I have nothing to disclose, and I'm really missing the conferences face-to-face and the time around the conferences with good friends, wonderful colleagues, to enjoy the times out of the conferences in the social aspects of conferences, and hopefully that would be one of the last virtual conferences in the future. So let's talk about the Shouldice repair. I had a great teacher from the Shouldice Hospital, Robert Ben David, who passed away too early 2 years ago. And in the following minutes, I will talk with his soul and my soul and our ideas we had together about the Shouldice repair in the 20th century and the 21st century as well. So we have guidelines, we have the international guidelines by the Hernia Search Group, and in these international guidelines, which are based on the guidelines of the European Hernia Society, the recommendation is to use a mesh repair in every adult patient with primary unilateral or bilateral hernias and in recurrent cases as well. But when we are going deep into the guidelines, there's written that mesh-based techniques compared to non-mesh techniques have a lower recurrence rate and the equal risk of postoperative pain. But there are limitations in these studies, which are the basis for these recommendations. But finally, in the guideline group concludes that the consistent results do make available findings reliable and usable in practice. There's no indication that mesh causes more chronic pain. It remains to be seen whether a mesh-based technique is indicated in all cases, such as small lateral hernias. The use of open non-mesh repair in specific patients or types, young males with lateral indirect type 1 hernias of inguinal hernia is an acceptable alternative to Liechtenstein technique, and it requires further studies. But they have written as well that there is a lack of clear chronic pain definition. There's a lack in the quality of the randomized trials. So these recommendation, this strong upgraded recommendation is not really based on scientific data. And when we are talking about specialized centers, then we have to have a look into this study from Ontario in Canada, where the Shouldice Hospital is based. And they were using data from the insurances to see where was the first primary operation, and if the patients are getting recurrences, they compared it with the hospitals where the primary surgery was done. And we see here the line, that's the Shouldice Hospital. The Shouldice Hospital is in the region of Ontario. The lowest recurrence rates compared to all other hospitals in the region of Ontario. That means not that the Shouldice hospital is superior to all the other techniques. It shows that when you are specialized in a surgical technique, you will achieve better results. So the discussion is, should we use a mesh or not? And in this Koch review, they have written that the problem is the quality of the included studies assessed with the Yadat scale were low, and the Shouldice technique is the best non-mesh technique. And these are the analyses of the studies, the meta-analysis of the EHS guidelines in 2009. And when we go deep into these studies, we see that most of the studies have not enough statistical power to give us clear results about chronic pain or recurrence. The quality of the included studies is very low, and we have not real scientific information when we are comparing non-mesh repairs with mesh repairs. And in the big databases from the United States, there's over 2 decades no decrease of recurrence rates. And in this randomized trial with a good statistical power, in the 5 years results doesn't show any difference between TAPP and Shouldice repair regarding to recurrences. And this is 20 years follow-up of one of the first randomized trials, TEP versus Shouldice repair. And in the Shouldice group, we had around 10% recurrences after 20 years. In the TEP group, around 25% of recurrences. We can discuss that this study was from the earliest time of endoscopic, laparoendoscopic repairs of inguinal hernias, but it is the only one which has a follow-up time of 20 years. And we see there's not really a difference between non-mesh repairs and TEP mesh repairs. Regarding to the recurrences, the non-mesh repair is in this study better than the mesh repair. And which patients are the right patients for a non-mesh based repair? And we have analyzed in HerniaMate, in a matched pair analysis, the patients who get a Shouldice repair in the primary surgery compared to TEP, Liechtenstein, and TAPP. And we were able to show that in a selected group of patients with younger age, smaller defects, lower BMI, and no relevant risk factors, the Shouldice technique can be used for primary unilateral inguinal hernia repair because we have the same results regarding to recurrences or pain compared to Liechtenstein, TEP, or TAPP. And here are the results. Compared with Liechtenstein, we have after 1 year better results for the Shouldice repair regarding to chronic pain, but no differences in recurrences. Compared to TEP, we have the same results for chronic pain and recurrences. We have a bit more intraoperative complications in the TEP group and a bit more postoperative complications in the Shouldice group. And compared with TAPP, there are no differences regarding to complications, pain, and recurrence rates. And the multivariate analysis of these data shows the same. For intraoperative complications, the Shouldice repair is a bit better. For recurrences, no difference. And for pain, the Shouldice repair has a bit better results, but not really significant better results. And when we are going back to the randomized trials, which are the basics for the recommendations. We have to read these papers until the end. That's one of the first randomized trial from 1998, Liechtenstein versus Shouldice, with a good follow-up time of 5 years. There were a bit more recurrences in the Shouldice group, a bit more pain in the Liechtenstein group, but for the statistical power analysis, we were able to show that there is not enough statistical power in this study to discriminate these results, to find out, is it really evident and is it really significant, these differences. And when we are reading the paper until the end, there was a comment by Nihus, and he said the disadvantage relates to the use of mesh in all patients. This one-suit-fits-all approach should not be promulgated. How can we individualize or tailor our surgery? At first, we have to use the classification, the EHS classification type 1, 2, 3, direct, indirect, combined, femoral, or recurrent hernias. And these are data from the group around Professor Schumpelik from the University of Aachen. And here we see in the primary hernias type 1, direct and indirect, there were 0 recurrences. And in the type 2, indirect hernias, 0 recurrences as well. And the bigger the hernias and the more direct hernias, here is the problem for the non-mesh repairs. Here we should discuss about mesh repairs. And the individual risk factors of the patients. Recurrent hernias have a higher risk of re-recurrences. Direct or combined hernias have a higher risk than indirect hernias. Bigger hernias in the age above 50 years. When the family is affected by hernias, we have a higher risk of recurrences, and smokers have a higher risk of recurrences. So how we can tailor our patients, how we can select the patients. When we have a smoker in the age above 50 and the family is affected, a mesh repair, open or laparoscopically, should be used. Young and healthy patients, here we should consider pure tissue repairs. And there is a gray zone. And in this gray zone, we need a possibility to tailor our approach intraoperatively. And for that, we need the open approach, because when we are using a laparoscopic approach, we have to use a mesh in any case. And that's what I mean with the gray zone. These are the direct hernias and combined hernias. The type 3 hernias, here, that's an indication for a mesh repair. Type 1 indirect hernia, clear indication for suture pure tissue repair. But this gray zone of these combined or direct hernias, here we should find a way to tailor our patients. And Robert Ben David has written in 1992 about prosthetics in hernia surgery. He was talking about and writing about the rational use of mesh in hernias. That's what we are talking about in the 21st century, and we call it the tailored approach. It's a rational use of meshes in hernias. Let me conclude this part. The EHS and international guidelines consider only the hernia itself. There's no real evidence for mesh techniques in every case yet. No differentiation based on their own classification. And in EHS 1 and 2 sizes of hernias, in young males, the suture techniques are the best option with low recurrence rates. Future studies need to consider the classification. We have to find out what's the best way for type 1 indirect hernia and for type 3 direct hernia and all the other types of hernias as well. What about the techniques? And in this textbook of hernia, we have well described, Robert and Ben David and me, the technique of the Shouldice repair. You can do it in local anesthetics or in general anesthesia or in spinal anesthesia. And then the preparation after opening the inguinal floor. Main step is to mobilize the inguinal ligament here on the cribriform fascia. And at the Shouldice Hospital, they are resecting the cremaster. I split the cremaster, I don't resect the cremaster. And then open the transversalis fascia, open the whole inguinal floor, and you can enter the preperitoneal space. And this is the part where we are able to place a mesh as well. When we made the decision intraoperatively, when we see how is the connective tissue, we can place a mesh in the preperitoneal space as a reinforcement as well. And I call this technique the reinforced Shouldice, and later on I will show you how that works. When we have opened the inguinal floor, then we start our first suture row medially. And when this row is finished, we go back from lateral to medial. And then we take the internal muscle to reconstruct the whole inguinal floor in the proper way. And this is, in my opinion, very, very good to reconstruct the floor, not only bridging the defect. And when you place a mesh in the preperitoneal space and you reconstruct the floor, then you are able to reduce your recurrence rates in these type 2 or 3 direct hernias as well. Finally, the fourth row, and then you're closing the inguinal floor by suturing the external aponeurosis, creating a new external ring, and then the operation is done. And when we are talking about the so-called reinforced Shouldice, you see here the transversalis fascia is open, we are entering the preperitoneal space, and we are able to place a mesh in this preperitoneal space, and we can use a long-term resorbable mesh as well. And especially in younger patients, we have no permanent mesh. These phasics mesh will be resorbed within 2 years completely, and we have a better reinforcement, we have a better scar tissue in the groin when we have reconstructed the floor. The results with phasics, I did 58 operations between 2015 and 2017. The most of the patients are male patients, and you see in M2 and combined 1 and 2 hernias, median operating time is 40 minutes, no post-perioperative complications, no complications in the follow-up. And until now, I have no recurrences, but with time, the first recurrence will come for sure. And with the permanent mesh, with the preperitoneal Onflex mesh, I did 270 patients in the same time, median age 56 years. And you see here mostly type 3 hernias and type 2 and type 3 combined hernias. And until now, I had 2 recurrences in that group. Let me conclude. The Shouldice repair could be the way to a real tailored approach for our patients. Non-mesh, absorbable mesh, permanent mesh. It's a possible alternative for permanent meshes except in type 3 direct hernias. We can prevent long-term mesh complications when we are using in that gray zone the absorbable meshes in the preperitoneal space combined with the Shouldice repair on top. And we have the anatomical restoration of the inguinal floor with additional reinforcement. We can use absorbable or permanent meshes. Many thanks for your attention, and I hope you have in the next hours a really good conference, and I'm waiting for your questions and I'd like to answer.
Yeah, there are a couple of questions. I saw a question by Dr. John Tanakumar. He's a senior surgeon, asks, what material does the speaker use in Shouldice for suturing the layers?
I'm using Prolene 2.0 polypropylene sutures.
Okay. And do you have any comments about the DESARDA repair? Any experience?
Yes, I have a lot of experience with the DESARDA repair because Ralph Lawrence and me, we introduced this technique in Europe and especially in Germany. And I think it's a good technique in selected cases, in smaller hernias. But in the most of the patients, I'm using the Shouldice technique. And when we are starting to talk about all the non-mesh repairs, then we need 2 hours to talk. And the DESARDA technique is a good technique in selected cases, but you need a very strong external aponeurosis to get the floor really good covered.
I've got one quick question, Andreas. What about female groin hernias? Can you explore through the open floor for a femoral hernia?
That's, in my opinion, in the Shouldice repair, when you open the transversalis fascia and when you're in the preperitoneal space, it's mandatory to explore the femoral gap to be sure that there is no femoral hernia. And in females, 2/3 of the female hernias are indirect hernias. You can repair them very well with the Shouldice technique. But you have to explore and you have to search for the femoral hernias. As we know, 15% of the women have femoral hernias. And in the Shouldice repair, you are able to place a preperitoneal mesh in the same plane like the laparoscopic repairs. And when you see femoral hernia, then you have to change intraoperatively to a preperitoneal mesh repair.